The Recovery Kernel. Substance-Specific Navigation Series. How to recover from ketamine. Using the Recovery Kernel Framework. Ketamine, Special K, Vitamin K, Ket, Dissociative Anesthetic Research Chemical Analogs. Warning: Harm Reduction Resource, not medical advice. Crisis, call 911 or text 988. Note: this guide addresses recreational ketamine use disorder and problematic use patterns. Medically supervised ketamine therapy, Spravato/esketamine, is a different context addressed in Section 1.3. A note before you begin. Ketamine sits at one of the most paradoxical positions in modern pharmacology. It is simultaneously a Schedule III controlled substance with significant abuse and addiction potential, a veterinary anesthetic, a club drug, and an FDA-approved treatment for treatment-resistant depression, as esketamine/Spravato. This guide exists for people whose relationship with ketamine has moved from recreational, therapeutic, or experimental use into a pattern that is costing them more than it is giving them. The Recovery Kernel Framework applies to ketamine recovery with several features that distinguish it from every other guide in this series. First, the primary organ damage is not neurological, it is urological. Ketamine-associated uropathy, the bladder and urinary tract damage from heavy ketamine use, is a medical emergency that is entirely separate from the addiction itself, and it requires its own treatment track that the Recovery Kernel Framework does not replace. Second, the psychological dependence often exceeds the physical dependence. Ketamine does not produce the classic physical withdrawal syndrome that opioids, benzos, or alcohol do, but the compulsive use pattern can be as entrenched as any in this series. Third, the dissociative state that ketamine produces has a specific psychological function for many users: escape from psychological pain, trauma, or a reality that feels unbearable, that must be addressed directly for recovery to be durable. And fourth, the same molecule that is destroying some people's bladders is being used to treat other people's suicidal ideation in supervised clinical settings. This complexity is held throughout this guide without trying to resolve it into a simpler story than it is. Section 0, Immediate Safety, read this first. Acute ketamine overdose, recognition and response. Classical building the Centurion. Ketamine overdose is primarily a respiratory and aspiration emergency. Ketamine does not produce the same respiratory depression as opioids, and it maintains airway reflexes better than most anesthetics. However, at high doses or in combination with other central nervous system depressants, it can produce complete dissociation and unresponsiveness, the K-hole at clinical severity. Vomiting while unable to protect airway, the primary aspiration risk. Respiratory depression, particularly when combined with opioids, alcohol, benzos, or GHB. Cardiovascular stimulation, elevated heart rate and blood pressure that can be dangerous in people with cardiac conditions. Psychosis, at high doses, ketamine can produce acute psychosis that is clinically indistinguishable from schizophrenia. Warning: if someone is unconscious and unresponsive after ketamine use, call 911 immediately. Roll to recovery position, on side, to prevent aspiration. Stay with them. Warning: combining ketamine with opioids, benzodiazepines, alcohol, or GHB dramatically increases overdose risk. There is no antidote for ketamine. The K-hole, when dissociation becomes an emergency. The K-hole is the colloquial name for the state of complete dissociation that occurs at high ketamine doses, a profound disconnection from body, identity, time, and reality that can range from terrifying to mystical depending on context, dose, and setting. At recreational doses in non-medical contexts, a K-hole is a medical emergency because the person cannot respond to their environment or protect themselves. Vomiting while in K-hole can cause aspiration pneumonia or death. Panic and extreme physical agitation can cause injury. The person cannot communicate distress or summon help. Response to K-hole: do not leave the person alone. Place in recovery position. Clear the immediate area of hazards. Monitor breathing. If breathing becomes irregular or stops, call 911. Do not give other substances to bring them out of it. Wait. They will emerge. The duration is typically 30 to 90 minutes for a full K-hole at recreational doses. The bladder, the emergency that cannot wait. Warning: if you have any of the following symptoms, see a urologist or emergency physician now. Do not wait for recovery to address this. Severe urinary frequency, needing to urinate every few minutes. Severe urgency, inability to delay urination. Pain in the lower abdomen, pelvis, or flanks. Blood in urine. Urinary incontinence, loss of bladder control. Upper urinary tract pain, kidneys, sides of abdomen, indicates possible kidney involvement. Ketamine-associated uropathy, KAU, can progress from mild irritative symptoms to complete bladder contracture requiring surgical removal. The only way to halt this progression is to stop using ketamine. But some damage requires active medical treatment regardless of cessation. Section 1.4 covers this in detail. If you have bladder symptoms, urology consultation is the first priority, before the supplement stack, before the protocol navigation, before anything else. Section 1, What ketamine did to your brain and body. Classical: building the centurion, the counterfeit sacred, simulating the highest without building the foundation. The Recovery Kernel Compendium describes ketamine through a specific lens from its centurion paper on the chakra system and substances. Ketamine simulates the highest center, the dissociative, ego-dissolving, transpersonal state associated with profound spiritual experience, while simultaneously destroying the most fundamental center. The compendium's exact language: the drug that simulates the highest center, third eye, simultaneously destroys the most fundamental center, root. This is the structural logic of the counterfeit sacred. This is not spiritual language imposed on a pharmacological reality. It is a description of what the neuroscience and the urology are showing. Ketamine produces states that humans across cultures have sought for centuries through meditation, shamanic practice, and near-death experience: ego dissolution, unity, release from the tyranny of self-referential thought, and it does so by blocking NMDA receptors throughout the brain, including in the urinary tract, where the blocking of those same receptors produces progressive, irreversible tissue damage. Understanding this dual reality, the genuine psychological value of the dissociative state and the genuine physical destruction of chronic high-dose use, is the prerequisite for everything that follows. 1.1, The NMDA receptor, what ketamine blocked. Classical: building the centurion, the brakes on excitation, and the engine of learning. NMDA, N-methyl-D-aspartate, receptors are a subtype of glutamate receptors, part of the brain's primary excitatory system. They play a central role in synaptic plasticity, the ability to form and strengthen or weaken synaptic connections, long-term potentiation and depression. Learning and memory, NMDA receptors are required for the encoding of new memories. Pain processing, particularly chronic and neuropathic pain. Mood regulation, NMDA hypofunction is implicated in psychosis and dissociation. Normal consciousness, the sense of being a continuous self embedded in a continuous reality. Ketamine is an NMDA receptor antagonist. It blocks these receptors, preventing glutamate from activating them. At subanesthetic doses, this produces analgesia, dissociation, euphoria, time distortion, and, at higher doses, the complete ego dissolution of the K-hole. At therapeutic doses in clinical settings, the same NMDA blocking produces rapid antidepressant effects, possibly by triggering compensatory glutamate surges that activate AMPA receptors and stimulate BDNF production. 1.2, What chronic ketamine use did to the brain. 1.3, The clinical context, when ketamine is the treatment. Classical: building the centurion, the same molecule, radically different contexts. Esketamine, Spravato, the S-enantiomer of ketamine administered as a nasal spray, received FDA approval in 2019 for treatment-resistant depression and in 2020 for major depressive disorder with acute suicidal ideation. Intravenous ketamine infusions are increasingly used off-label for the same conditions through licensed infusion clinics. This guide is not for people using ketamine in medically supervised therapeutic contexts with proper integration support. The compendium notes, the therapeutic dose exception, clinically administered ketamine at appropriate doses, with integration support, is a different intervention. The clinical model provides the container the recreational use lacks. However, 3 situations exist where therapeutic ketamine and this guide intersect. Therapeutic ketamine use that has escalated into self-administration, dose escalation, or use outside the prescribed clinical context. This is now recreational use disorder regardless of how it began. People who are in ketamine therapy for depression and are also recovering from recreational ketamine use disorder, the therapeutic use must be managed in full coordination with both the ketamine clinic and the recovery support system. People considering ketamine therapy for treatment-resistant depression who also have a history of recreational ketamine use, this requires specialist consultation before therapeutic use begins, as prior high-dose use may have altered NMDA receptor architecture in ways that affect therapeutic response and risk. 1.4 Ketamine-associated uropathy, the organ damage that cannot be ignored. Warning: ketamine-associated uropathy is a progressive and potentially irreversible condition. The only way to halt progression is to stop using ketamine. Some damage requires active medical treatment even after cessation. Ketamine-associated uropathy, KAU, is one of the most severe and distinctive complications of heavy recreational ketamine use. It was first documented in clinical literature in 2007 and has become one of the defining medical risks of the current recreational ketamine landscape. If you have any urological symptoms, the first appointment you make is with a urologist, not with an addiction medicine specialist, not with a therapist. The bladder damage is the medical emergency. The addiction framework supports everything that follows. But the urology comes first. Section 2, Your Genomic Blueprint. Ketamine recovery has a specific genomic profile centered on 2 genes that the Recovery Kernel Compendium names explicitly in its practitioner reference, CYP2B6, the dissociative logjam risk gene, and COMT, determining the specific character of the dissociative state's appeal. Understanding your profile also helps predict bladder damage progression risk and cognitive recovery timeline. The DNA testing panel for ketamine recovery. Phenotyping without test results. If genetic testing is not yet available, ask yourself: did ketamine affect you much more intensely or last much longer than it seemed to for others at the same dose? Likely CYP2B6 poor metabolizer. This is clinically significant information. Your accumulated ketamine exposure per gram used was higher than average. Was the primary appeal of ketamine the complete cessation of thought, the escape from anxious rumination, or the sense of being freed from the burden of consciousness? Sage constitution, Met/Met COMT, plus likely SLC6A4 involvement. Depression and anxiety are the underlying conditions requiring direct treatment. Was the primary appeal the euphoria, the social dissolution, the sense of infinite possibility and connection? Warrior or mixed COMT plus DRD2 deficit components. The natural addiction porting needs to build those states through other means. Did ketamine seem to treat depression that nothing else had touched? MTHFR variant plus possibly appropriate candidate for supervised therapeutic ketamine for depression, but only after recreational use is addressed and under specialist oversight. Do you have a family history of multiple addictions or a chronic sense of something missing? DRD2 deficit/RDS profile. Multiple natural dopamine sources essential. Section 3, Detox and Withdrawal. Classical building the centurion, ketamine withdrawal is primarily psychological, but that does not make it less real. Ketamine withdrawal does not produce the seizure risk of alcohol and benzos, the life-threatening cardiovascular instability of stimulant acute toxicity, or the severe physical suffering of opioid withdrawal. For most users, it is not a medical emergency. What ketamine withdrawal does produce is a specific constellation of psychological symptoms that can be severe enough to drive immediate relapse, and a glutamate rebound state that produces anxiety, cognitive disruption, and perceptual disturbances that are genuinely distressing. The absence of dramatic physical withdrawal does not mean the person can simply stop without support. The withdrawal syndrome, what to expect. The CYP2B6 dissociative logjam, extended withdrawal in poor metabolizers. Classical building the centurion, if ketamine always hit you harder and lasted longer, this section is for you. Poor CYP2B6 metabolizers clear ketamine dramatically more slowly than normal metabolizers. The clinical implications for withdrawal. Withdrawal onset may be delayed, ketamine clears more slowly, so the NMDA rebound happens later than expected. Withdrawal symptoms may be more severe and more prolonged, the accumulated NMDA receptor upregulation from longer drug exposure per gram used. Cognitive impairment in early recovery may be more pronounced and last longer. Bladder damage may be more severe for the same reported dose history, longer urothelial exposure to active ketamine. If you suspect CYP2B6 poor metabolizer status, inform your recovery physician and any specialist providing treatment for ketamine-related organ damage. The dose history may underestimate your true ketamine exposure burden. Section 4. Biological reconstruction. Ketamine recovery requires reconstruction of three systems: the NMDA/glutamate system, the primary pharmacological target, the dopamine system, secondary damage, and the cognitive architecture, the prefrontal and hippocampal functions that chronic NMDA blockade impaired. The methylation foundation underlies all three. Additionally, if bladder damage is present, urological recovery runs as a parallel track. 4.1 The Methylation Foundation. Same foundation as every guide in this series, with one ketamine-specific emphasis. If ketamine was being used partly for its antidepressant-like effects, addressing MTHFR variant methylation impairment is the most important early intervention for managing the depression that will emerge in withdrawal. 4.2 Glutamate/NMDA system support. Classical building the centurion, managing the rebound, and supporting the recovery. The glutamate rebound of ketamine withdrawal is the acute pharmacological crisis. The NMDA system's recovery over the following months is the structural rehabilitation. Both require specific support. 4.3 Cognitive recovery, the KFuzz clears. Classical building the centurion, the mind that was blocked is coming back online. The cognitive impairment of heavy ketamine use, what users often call KFuzz or KFog, reflects genuine neurological disruption. NMDA receptor dysfunction in the prefrontal cortex and hippocampus impairs working memory, attention, word finding, and the clarity of thought that makes engaging with reality feel worthwhile. For CYP2B6 poor metabolizers, this impairment may be more severe and more prolonged. The cognitive recovery timeline is generally 3 to 12 months for most users, with accelerated recovery in those who maintain vigorous exercise throughout. The mechanism: BDNF production from exercise drives hippocampal neurogenesis and synaptic plasticity, the same processes that ketamine's antidepressant effects were stimulating artificially. Exercise, primary intervention 30 to 60 minutes aerobic daily. BDNF increases of 200 to 400%. This drives cognitive recovery faster than any supplement. The cognitive fog lifts measurably faster in people who exercise vigorously throughout recovery. This is the single most important cognitive intervention. Alpha-GPC or CDP choline, 250 to 500 mg morning acetylcholine support for memory and attention. Ketamine impairs cholinergic function through NMDA-related mechanisms. Choline supplementation supports the recovery of memory encoding capacity. Lion's mane mushroom, 500 to 1000 mg daily NGF stimulation driving neurite outgrowth and synaptic repair. Specifically supports the hippocampal plasticity most relevant to the memory deficits of ketamine use. DHA, 1000 mg plus daily structural support for neuronal membranes containing NMDA receptors. Supports BDNF signaling. Anti-inflammatory effects on the neuroinflammation from NMDA excitotoxicity. The 40 Hz gamma protocol, the compendium's sonic architecture section specifically identifies 40 Hz binaural/isochronic tones for their potential role in supporting the brain's lymphatic clearing processes and neural repair. 30 to 60 minutes daily as a cognitive recovery adjunct. Consistent use over months, not a quick fix, but a supportive background intervention. Novel skill learning, challenging new skills drive BDNF in specific brain regions. An instrument, a language, a physical skill with a learning curve, anything that generates errors and requires attention to correct. The prefrontal cortex damage from ketamine responds to exactly the conditions that skill learning creates. 4.4, Dopamine and serotonin reconstruction. 4.5, the urological recovery track. Classical building the centurion, the bladder heals when given the chance, but it needs help. Urological recovery from ketamine-associated uropathy runs parallel to the neurological recovery protocol and requires its own medical track. The supplements below have been studied or have mechanistic rationale for urothelial and bladder recovery. They do not replace urological medical care. Warning: all urological supplements should be discussed with your urologist. Some, particularly high-dose vitamin C, can acidify urine and worsen bladder irritation in some patients. 4.6, Sleep reconstruction. Ketamine disrupts sleep architecture through multiple mechanisms. NMDA receptor disruption affects sleep regulation, the dopamine and serotonin disruption impairs sleep quality, and the psychological dependence often involved using ketamine specifically for sleep, the dissociative state as a substitute for genuine sleep. The vivid, disturbing dreams that often accompany early ketamine recovery are REM rebound, the brain reclaiming the restorative sleep stages that ketamine was suppressing. Melatonin, 0.5 to 1 mg sublingual, 30 to 60 minutes before bed. Low dose. High doses disrupt circadian rhythm. Magnesium glycinate, 400 mg elemental, evening. NMDA modulation, anxiety reduction, cortisol buffering, all support sleep onset. Glycine, 3,5G, 30 minutes before bed. NMDA coagonist at inhibitory doses, reduces core temperature for sleep onset, improves sleep architecture. L-theanine, 200 to 400 mg evening. Alpha wave promotion, reduces the glutamate rebound anxiety that prevents sleep in early ketamine recovery. 5-HTP, 50 to 100 mg evening. Serotonin-melatonin synthesis support. Important if depression-related insomnia is present. Also execute Protocol 17, Sleep Architecture, from the main compendium in full. 4.7, Peptide Support Layer. Physician discussion required, research compounds. Section 5, The Ketamine Craving, Understanding and Interrupting. Classical building the centurion, the craving is not for the drug. It is for the exit it provided. Ketamine cravings have a specific quality that distinguishes them from stimulant cravings, which feel like hunger for more, or opioid cravings, which feel like pain-demanding relief. Ketamine cravings tend to feel like the overwhelming desire to leave. To exit from consciousness, from reality, from an emotional state that is too large to tolerate. The craving arrives when the present moment becomes unbearable, and ketamine's offer is the most efficient exit available. Understanding this changes the interrupt protocol. You are not fighting a desire for a substance. You are meeting a need for exit from an overwhelming state, and providing an alternative exit that does not require dissociation. The ketamine craving types. The ketamine craving interrupt, 5-minute protocol. Identify the type. Reality escape. Depression/anhedonia. Curiosity/exploration. Social/contextual. The type determines the primary response. Ground immediately. 5 things you can see. 4 you can physically touch. 3 you can hear. 2 you can smell. 1 you can taste. This is not a metaphor, it is prefrontal cortex activation and present moment anchoring that interrupts the dissociative exit the craving is seeking. Execute 4-7-8 breathing. 4 full cycles. The parasympathetic response reduces the overwhelm that made the exit feel necessary. Cold water on face and wrists. The dive reflex activates within seconds, immediate parasympathetic shift. This is the fastest available grounding intervention outside of the breath. Make contact. 1 text or call. The isolation of dissociation is part of the pattern ketamine created. Contact is its structural antidote. Execute your natural state. From Section 6, Movement, Breathwork, Meditation, Cold Plunge, Creative Work. You are not suppressing the need the craving represents. You are meeting it differently. Document. Trigger, type, intensity, 0 to 10, action, outcome. The ketamine craving pattern documented over weeks reveals the specific internal states and external contexts that are driving the difficulty. This is diagnostic information for the therapy and for the natural addiction architecture. Section 6, Porting the Addiction, Genuine Access to What Ketamine Faked. Classical Building the Centurion, Centurion Paper C28, The Counterfeit Sacred Becomes the Real Thing. The compendium describes ketamine as the counterfeit sacred. It simulates states that human beings have sought through contemplative practice, ritual, and spiritual discipline for thousands of years. The ego dissolution of the K-hole maps precisely onto what contemplative traditions describe as the dissolution of the small self. The expanded awareness of subanesthetic doses maps onto what meditators in deep practice report. The sense of connection with something larger than ordinary consciousness is not unique to ketamine, it is a neurological state that the human system was designed to access. The difference between the ketamine version and the authentic version is exactly what the compendium names. The ketamine version provides the state without requiring the development of the architecture that makes the state sustainable, integrable, and genuinely transformative. The contemplative version requires years of practice and genuine transformation of the person who inhabits the state. Ketamine recovery is unique in this series because the natural addiction architecture is not primarily about building intensity, stimulants, endorphin warmth, opioids, GABA calm, benzos/GHB, or anandamide flow, Cannabis. It is about building genuine access to the transcendent states that ketamine was counterfeiting. This is the most demanding natural addiction architecture in the series, and potentially the most rewarding. The grounding architecture, presence before transcendence. Classical building the centurion, you cannot integrate what you have not embodied. The first task is the inverse of what ketamine was doing. Before building genuine access to expanded states, the person in ketamine recovery must build the capacity to inhabit ordinary states, to be present in their body, in the moment, in their actual life, without reaching for the exit. This is somatic work. It is the work of coming home to the body that ketamine was helping escape from. For many people in ketamine recovery, the body is where the unprocessed material lives, the trauma, the grief, the anxiety, the pain that the dissociation was providing relief from. Recovery requires building the capacity to be with that material without being destroyed by it. Somatic therapy, Protocol 23 in the main compendium, or external specialists specifically for people whose ketamine use was managing trauma or emotional pain stored in the body. EMDR, Somatic Experiencing, Sensoromotor Psychotherapy. These approaches work with the body's experience directly, the opposite of ketamine's body exit mechanism. Grounding practice, 5-4-3-2-1 Sense anchoring practice daily until it is as automatic as the former ketamine use. The nervous system needs to build the neural pathway for returning to present moment embodied awareness. Physical exercise specifically as embodiment, the goal is not fitness. It is presence in a body in motion. Running, swimming, martial arts, dancing, any physical activity that requires full attention to what the body is doing right now. Safe physical contact, for people whose ketamine use involved social contexts, rebuilding the capacity for physical presence with others without chemical disinhibition is part of the grounding work. The transcendence architecture, the real thing. Classical building the centurion, the states ketamine faked can be accessed genuinely. Section 7, Navigating the Recovery Kernel, your protocol map. Section 8, the medical support layer. Addressing the underlying depression. Classical building the centurion, the condition ketamine was treating may need its own treatment. A significant proportion of people with ketamine use disorder began using partly because ketamine produced rapid and profound antidepressant effects that conventional treatments had not. The depression does not disappear with cessation, it returns, often more intensely, in the early weeks of recovery. This depression must be treated directly. Options, in order of preference. 5-MTHF, 400 to 1000 micrograms, plus methylcobalamin. If MTHFR variants are suspected or confirmed, this is first line. Addresses the specific methylation deficit mechanism that makes some people's depression unresponsive to SSRIs. Try for 6 to 8 weeks before concluding insufficient. SSRIs or SNRIs, with CYP2D6/2C19 metabolizer status guiding selection. Discuss with psychiatrist. Note that SSRI response in people with ketamine use disorder is sometimes complicated by the NMDA system disruption. Allow adequate trial periods. Supervised therapeutic ketamine, esketamine/Spravato. If the depression is genuinely treatment-resistant and other options have been exhausted, supervised ketamine therapy may be clinically appropriate even in the context of recovery from recreational ketamine use. This requires specialist addiction psychiatry input, not a general ketamine clinic. TMS, transcranial magnetic stimulation, non-pharmacological treatment for depression with strong evidence in treatment-resistant cases. Modulates glutamate and NMDA pathways through electromagnetic stimulation, mechanistically relevant to ketamine recovery. Managing persistent dissociation. Some people in ketamine recovery experience persistent depersonalization and derealization, feeling disconnected from themselves or their environment as a default state even without the drug. This can persist for months and is one of the most distressing features of heavy ketamine use. Persistent dissociation in recovery is addressed through somatic therapy, primary working with the body's experience directly to rebuild the sense of inhabiting a self. Sensoromotor psychotherapy, somatic experiencing, EMDR. Grounding practices, daily 5-4-3-2-1 sensory anchoring. Cold water exposure. Physical contact with safe people. SSRI therapy. SSRIs have evidence in depersonalization disorder, which shares mechanisms with ketamine-induced persistent dissociation. Avoiding cannabis and other dissociative substances. Cannabis use in ketamine recovery can significantly worsen depersonalization/derealization. Avoid urological medical track. The urological recovery runs parallel to the addiction recovery and requires its own specialist team. Urology consultation. If any urological symptoms exist, this is the first medical appointment. Not addiction medicine. Not psychiatry. Urology. Cystoscopy, direct visualization of the bladder to assess the degree of structural damage and guide treatment planning. Renal function tests and ultrasound, to assess for upper urinary tract involvement. Hydrodistension, a urological procedure that stretches the bladder under anesthesia, can provide temporary symptom relief and allows assessment of bladder capacity. Intravesical therapies, direct bladder installations of anti-inflammatory agents, hyaluronic acid, chondroitin sulfate, to support urothelial repair. Urology follow-up, 3 monthly for at least the first year of cessation to track recovery or progression. A final word. Classical building the centurion, the exit door was real. The building you were escaping from is where the life is. The compendium's description of ketamine as the counterfeit sacred is not a moral condemnation. It is a precise pharmacological and phenomenological observation. The states ketamine produces are real. The ego dissolution, the sense of expanded awareness, the release from the tyranny of the self-referential mind, these are genuine neurological events that map onto states human beings have sought and valued across every culture in recorded history. What makes them counterfeit is not their character but their consequences. The path that provides them without the development, without the years of contemplative practice, without the gradual building of the psychological integration capacity, without the steady cultivation of the ability to remain present in ordinary states, also provides them without the fruit. The insight that cannot be integrated. The expansion that cannot be sustained. The peace that requires another dose. And, increasingly, a bladder that is slowly being destroyed by the molecule that was providing the transcendence. Recovery from ketamine is not the abandonment of the states you were seeking. It is the discovery of the path that actually leads there. The meditation hall is built for exactly what the K-hole was approximating. The float tank provides sensory dissolution without NMDA receptor damage. The breathwork session produces the ego boundary dissolution through means the body owns rather than means the pharmacy supplies. The flow state of physical mastery creates the sense of effortless, timeless absorption that sub-anesthetic ketamine was producing chemically. The difference is that these paths build something. Each session leaves a residue, a slightly more developed capacity to inhabit the full range of human experience. A slightly more stable foundation for the next expansion. A slightly deeper integration of what the previous expansion revealed. Ketamine was leaving a different residue. In the urothelium. In the prefrontal cortex. In the NMDA receptors that were trying to maintain the conditions for genuine consciousness. The building you were escaping from is where the life is. The recovery kernel framework is the map for inhabiting it. Ketamine-associated uropathy, see your urologist before anything else. Refer to the Recovery Kernel Complete Centurion Compendium for all referenced protocols. Crisis, call or text 988 Emergency, 911 SAMHSA, 1-800-662-4357. Warning: harm reduction resource, not medical advice. How to recover from ketamine using the Recovery Kernel Substance-Specific Navigation Series.